Hi there. Hope everyone watching this panel is doing well today. Welcome to Trans Health Equity. This panel is part of the New Haven Pride Center's Trans Awareness Week programming, curated by trans, non-binary, and intersex program officer Elliot Olson. My name is Maya Leonardo. I am the Marketing and Development Coordinator here at NHPC. Today, I'll be facilitating a conversation between Dr. A.C. Demidon, Principal Medical Scientist, HIV Prevention and Medical Affairs at Gilead Pharmaceuticals, Dr. A.J. Eckert, Medical Director of the Gender Affirming Program at Anchor Health Initiative, and Ivy Seklo, Hotline Program Director at Trans Lifeline. Today, we'll be talking about some of the inequities and barriers to care experienced by members of the trans community when accessing healthcare, what healthcare professionals can do to better treat trans patients, and how trans people can advocate for themselves when accessing healthcare. So I'm going to give my panelists a chance to introduce themselves. If there's anything else they'd like to say about their qualifications and experience. No. All right. So, start with some statistics. 31% of trans Americans lack regular access to healthcare. 22% of trans people said that they had avoided doctors or healthcare for fear of being discriminated against. 20% of Black transgender women are HIV positive. 40% of trans people have attempted suicide in their lifetimes. So, trans inequity in healthcare is definitely a problem in this country. And I'd like to ask the panelists, what is the root of your commitment to healthcare? What drives you?
I guess I'll start. For me personally, I have been in the LGBTQ community since I was a kid. Growing up, being born into the family that I have, of my family of origin, having chosen family was always very, very important to me. And so I've always felt part of the queer community, and I've done advocacy really since high school. So it's always been something that's been really important to me to continue doing. And so that's how I ended up doing that, even past medical school and then residency, and into at one point opening my own clinic for LGBTQ patients. Currently, I'm heading the gender affirming program at Anchor Health Initiative, and in that way, again, supporting the community the best way that I know how to with the knowledge I have.
Ivy, go ahead.
Okay. Yeah. I mean, mental health is often viewed as something that's very separate from physical health. And anybody who's studied either of those things knows that that's not true. It's very deeply interconnected. So I'm a big believer in mental health being represented in any conversation around any other type of health, because there's so much interconnection there. For me personally, what always drove me towards supporting trans people in mental health work is just the fact that there has always been a lack of representation by trans people in our field. And a lot of the time, Maya was mentioning some statistics. It's no different in mental health. A lot of trans people simply avoid accessing mental health services or peer support services because there is no basic respect given to us there, and there's no real understanding of the trans experience. So when I got my education in mental health in psychology and law, I was looking both through a lens of providing potentially mental health services to my community, and also being able to advocate for my community in situations where trans people are very frequently criminalized. So that's my background. And I ended up going to peer support instead of any sort of legal or criminal justice orientation. And that's where I intend to stay for the foreseeable future, because being able to work exclusively with our community is a real blessing.
So I can say, as somebody who's older than many of the people on this panel, I grew up at a time when there was zero visibility or representation for trans people, or even really queer people in medicine at all. And so the only information that we learned was around HIV. And so the reason I went to become an infectious disease doctor was because I wanted to work with HIV patients and give back to my community. You know, I'm old enough to have lived through the early days of AIDS. So, I think that my experience after training was to only work in LGBT healthcare. And so that's why I started Anchor Health Initiative in the first place. And now I've gone on to work in a different capacity where, I get to make sure that the trans voice is heard on a global scale in pharmaceutical research, because a lot of times trans people have been left out of, even though the statistic that you talk about, the number of trans women who are HIV positive, or the rates of HIV positivity and trans people, we've been excluded from a lot of research trials. So, just on my team at Gilead, there are 2 out trans women. So, we now get to be able to talk about making sure that pharma includes all people in the gender spectrum in clinical research, particularly around, life-threatening illnesses like HIV. And, unfortunately, I can't influence everything in pharma yet, but we'll see. Give me a chance. Give me a few years and we'll see how I can do it. But, even talking about like why they don't study testosterone, new testosterone products, why they don't study that in trans masculine individuals is, something. All of that is what drives me, is that question mark of like, why are we excluded? Who's doing the excluding, and how can I change that and make sure that we're not excluded from the conversation?
Yeah. Well, great. Thank you, folks. So how has COVID impacted trans healthcare?
Well, I mean, I think that a lot of what's been impacted is the ability to come into the office, so come in for physical office visits. So, and not just as far as trans healthcare, just healthcare in general. And so a lot of us are doing telehealth. I have noticed that I do have patients who actually prefer that, so that they can be in the comfort of their own homes and having a doctor's visit that they might actually usually come in and have a lot of anxiety around. So to be able to do that from the comfort of their homes has actually been really nice. So having that option, that telehealth option, has been really great for some people. Others, I mean, I have seen that mental health disparities, mental health problems have definitely worsened throughout the pandemic. Hard to be able to, because as a community, we do a lot of things together and connect with others and do that in physical spaces. So that's been really hard to maintain. And with everything going online, it's been huge adjustments.
Yeah, definitely seconding what Dr. Eckert's saying. From a mental health standpoint, there's definitely a lot of spikes in particular types of crisis and stressors. So, for example, on our line, we're seeing an uptick in domestic and intimate partner violence related calls. So obviously that impacts people's both physical and mental health. But with regard to telehealth, it's like Dr. Eckert was saying, it's kind of a double-edged sword, because on one hand, you have the possibility of more accessibility to more trans competent providers. There's a lot of people right now that are seeking providers both in physical and mental health. And they have a hard time getting in with people who are maybe further away, but more and more doctors opening up telehealth options to their clients provides potentially more opportunities for trans competent care, which is great. But at the same time, let's say you live with an abusive partner and you cannot actually talk to your provider in privacy. You can't actually talk to your mental health or your medical provider in privacy. And you can't maybe disclose some things that would be very important for that person to know. So there's a lot of additional adversities that are added on to that. And then also adding on to that, I'm sure a lot of people have been seeing, but there's a lot of uncertainty created by the pandemic around people accessing things like gender affirming surgeries. A lot of people's surgeries are being pushed off indefinitely. A lot of people are experiencing enormous amounts of anxiety and dysphoria and distress around that. And that is both a physical health and a mental health issue. We're getting an enormous amount of uptick in calls around that issue as well. So, yeah.
Yeah, I just like what everybody else has said, one of the things that definitely has happened for, at least in terms of HIV and healthcare in general, is as people who may have had service industry jobs or were working in, waitresses or things like that, a lot of those jobs have been completely eliminated. And so, there certainly has been an increase in the amount of sex work that has been going on for people in response to COVID, simply because it's available, right? Like people are able to work, and we know that because of FOSTA and SESTA, like for trans people, accessing sex work has become more challenging and more dangerous because you have to go back out on the street, and you may not have had the same avenues to work as we did before FOSTA and SESTA. So I think one of the really scary things that, a city like Rochester, New York, since March, they've had over 30 new HIV infections, which is a huge increase compared to what they would normally see, primarily because people haven't been able to access their PrEP. They haven't been able to access their provider to get their STI testings done. And then, I think a lot of times it's very challenging for trans people to even start that process. And then when things change, it becomes really even more tricky, because, the fact is that we don't trust medicine for good reason. And so when suddenly things change, like people definitely, I think, have a, hesitancy to engage with new processes because it can be really scary and new. And so the result of that has been the expectation that we're just going to sit at home and be poor and broke and not work, and I think initially, trans sex workers in New York had a huge issue with this, where they were expected to not work. And I mean, how can you not work and live in this world today? So if you even look at the World Health Organization put out a how do we have human rights during COVID and social distancing? And, sex work is work. And if that's your job, then we have to figure out a way to support you during COVID and make sure that you don't get HIV and make sure that you get all the screenings that you need and that you're safe and working in a safe environment. So, I think that that's one of the things that I've pushed very hard for during COVID, is to make sure that people understand that, if you're doing sex work, that is a job, and like social distancing is not the answer. Like if you're a sex worker, you have to figure out how to do it safely, right? So, or as safe as possible.
Yeah, definitely. It's a huge one. We've been having a lot of conversations around that too. It looks like we lost Maya, but we all have the list of questions, so I can pretend to be the person. So doctors, what are the biggest shortcomings within healthcare for trans people? What do we think?
Jeez.
Like, what
Everything.
Isn't, right?
No, just
Yeah, seriously, it's such a loaded question. There's so much. I think you're right. It's kind of like those surgeries that in our community we would deem essential because they are for if for dysphoria, for safety, that are being seen now as surgeons can put them on hold because they're considering them cosmetic. It's just widening those disparities, that marginalization that we already knew was there is really increasing, and we're seeing it a lot more, I think, with the pandemic and the effects. But in general, I mean, healthcare access for LGBTQ people, I mean, it's why we have a program here, right? It's why we have a program that is intended to be a safe and trauma-informed space for our community, because there are so many doctors out there that really are very comfortable saying, "Oh, I don't know what to do with you because of your gender identity or because of your sexual orientation. So I'm just going to send you off to a specialist." And they have absolutely zero qualms. And I find that to be something that leads a lot of people to not accessing healthcare at all, or to having just a lot of barriers to even wanting to come back in and talk to someone else. It's simple things like using pronouns like dead naming. I mean, this is stuff that cis people don't think about on a day to day, that really really affects someone when they make a decision that this is going to be a safe space for me to talk. And so just to have to think about the fact that, like, you want a healthcare system where you feel like supported and safe. I mean, that's like the basic thing, but then, I mean, everything on top of that, right? As far as the inequities, but that's where it starts.
Yeah, I mean, I think stigma is the overall biggest barrier to healthcare for queer and trans people particularly. And do I think that Joe Biden being elected president, I think he's going to be the president. I assume he's going to be the president, but do I think that's going to make a big difference in terms of like stigma, in the dispersion of stigma? Maybe it'll make it a little better. But remember, I mean, stigma is a top-down phenomenon. So if a trans little kid wakes up in the morning to see like news on the internet about a bathroom law being written like specifically about them, that's where it all starts. And I think that filters down into medical education, that we don't teach healthcare providers or mental health providers how to care for LGBTQ people. Maybe we teach them a little bit about like gay and bisexual men because of HIV, but we definitely don't teach them about, it's stunning to me when I go out and I see like people have no idea the difference between gender identity and sexual orientation. And like, even when you tell them like how much younger people develop their gender identity than sexual orientation. But I mean, I think overall, like the overarching issue that has caused all of this is that there's huge stigma towards trans people, and it is pervasive, and it is one of the only places in this country where you're allowed to full on like just do whatever you want and say whatever you want about those people, and you get away with it on a like very public and political level, where you can't do that for most populations, but for trans people, we are the low-hanging fruit, and people have chosen over the past 4 years to continue to stigmatize us. So I think that's what the main barrier for healthcare in general is that stigma is so pervasive in this country for trans and non-binary people.
Yeah. And speaking
For sure. Hmm? Oh, I was
go
going to
ahead,
answer,
go ahead.
but go ahead. Okay. Yeah, I mean, echoing what everyone said, I think like if I were to make a very broad generalization about the multitudes upon multitudes of issues that that impact us, right? When we talk about providing competent care, a lot of the time, like people will use language like we need to be inclusive, or we need to be, like trans competent, or we need to be like culturally competent, or have cultural humility, like all these different right expressions, which are all great and they're all like accurate in their own way. But specifically in the context of providing healthcare and providing mental or physical healthcare, the way that I really, really like to frame both the problem and the solution is lack of accuracy and a severe, severe epidemic of misinformation. And, as an intersex person, one of the ways that you constantly see that arising is people literally who are supposed to be professionals absolutely not knowing how to interact with people who have diverse bodies in general, whether it's because you're trans or because you're intersex or for any other reason. Medical professionals who are supposed to be the highly paid professionals who are experts on treating people's bodies do not know how bodies work or how they're supposed to work. That's the reality. And so when we look at the medical system and when we look at the mental health care system, and you read, you know, the DSM, you read anything that professionals and providers are taught, it is based on this fundamental, enormous breadth of misinformation about this is how men operate, this is how women operate, this is the two types of bodies that exist, this is, you know, the different issues that can arise mentally for people with this particular body type. It's all very, very, very simplistic and very, very, very misleading. So when I was, you know, when I was in college and I had a child and adolescent development professor who had an entire lesson dedicated to teaching people about how transness and being intersex is an anomaly, and she particularly taught that intersex people have medical conditions and are sick, and that there's something wrong with us, right? And then fast forward to just the past year, where I saw a lot of LGBTQ organizations trying to raise awareness right around like Intersex Awareness Day or whatever, and being like, people with intersex medical conditions. Again, like using that stigmatizing language is something that's very, very widespread, and something that spreads both culturally and also into spaces where people interact with providers. And I guess the last thing that I wanted to say, sorry, I've been on a soapbox for a while, is something that's really not talked about a lot is how much power medical providers have. When we talk about issues faced by trans people, one of the most frequent places for a trans person statistically to experience sexual assault is in a hospital. There's so much power that's held in the hands of a mental health provider who might refuse to write you a letter, or might say, you have too many mental health diagnoses for me to comfortably consider you trans enough to medically transition. If somebody has a history of non-consensual psychiatric hospitalization, depending on where they are, that could preclude them from years later accessing surgery. So there's a lot of power that's held by providers, and not enough responsibility taken by providers to actually educate themselves and provide competent care that doesn't re-traumatize people.
Yeah, thank you for that, everyone. Dr. Demidant talked about stigma, and I was curious about how you see stigma related to specifically HIV in trans people versus cis people, and what barriers that creates for prevention and treatment.
That's a great question. I think there's both stigma within the trans community, particularly for trans women, like not wanting to identify as being HIV positive, not wanting to talk about our status, because it precludes you from working sometimes, because it precludes you from having relationships sometimes. And then because also, there is a lot of chatter in the community itself about like people's status, and the idea that if you're HIV positive, you are somehow like defective or damaged or infectious or whatever vectorizing word you want to use to talk about HIV positive people. I think there's that stigma. And then I think that there's the stigma of people have no idea. There's so much myth around like HIV medications and hormones and like the interaction between them. And if there really is some kind of interaction, which, the most recent data would suggest there is no interaction between hormones and antiretrovirals. So, but on the street, you'll hear oftentimes girls won't take their meds because they think it makes your estrogen disappear. And, there's no data that would support that, but that's sort of like a myth that's out there. for non-binary and transmasculine people, there's just really like nothing about HIV. And well, there is a little bit now, more recently, but for many years, it was just sort of like, nobody even asked you a question about who you had sex with. It was just about your gender identity. And it wasn't as if you were a transmasculine person, you didn't have a sexual orientation, and you may only have like front sex with cisgender men, which makes you at risk for HIV. So, you know, that's stigmatizing, right? Because providers never included transmasculine people in the discussion about HIV prevention and how to make sure that how to make sure those people are protected from HIV. And then there's like the global sort of stigma around, it always bothers me so much, because as trans people, we actually have to encounter medicine. Like, I don't need to give you a pill to like make you gay. Like, I don't need to give you a pill to like affirm your lesbianism. But so a lot of times those young LGB people, they never have to come in contact with medicine because they don't need any medicine to affirm them. And yet, like, that stigma is, we show up to get hormones, we show up to get letters and get mental health because everybody's convinced that we have a problem. And still, the HIV prevention strategies that are out there and known to be effective are not implemented for us when we show up at the endocrinologist's office, because they don't do HIV testing or they don't do HIV prevention. So like, it's this very global and pervasive stigma around in the community of people who provide care to trans patients. And, you know, if you don't end up at a place that does hormones and PrEP, like, the scattering or the, you know, fracturization of your care has been shown to, like, if you ask a trans woman, you know, like, what are your top 5 priorities, and they're HIV positive, HIV is like at the bottom of the list of their top priorities. Our priorities are like affirming care, hormones, mental health, like hygiene, safety, and then like antiretrovirals at the bottom. So it's sort of like medicine doesn't know how to meet people, and society doesn't know how to meet people where they are. They try to force what they want on us, not what we need incorporate into their healthcare systems. So, I mean, it's very pervasive, and it's why trans women are 49 times more likely than cisgender women to become HIV infected throughout their lifetime, and why adolescents, you know, trans kids are more likely to become HIV positive in their adolescence than cisgender kids, because it's like people can't see the whole picture of a trans person. They only see like the little, like the hormone part or the mental health part or the surgery part. And we need more that destigmatization of like the trans experience, and what we need, I think, will change HIV prevention and HIV treatment as well. I don't know if that made sense. I could go on for hours about that. I could write a doctoral thesis about that, by the way. So like,
You should. Another one.
Yeah, I mean,
A book.
Dr. Eckert, IV, would either of you like to take a stab at that question? Or
Oh.
The one in the chat?
No, just the one I just.
The DSM question, or because I'm happy to take a stab at that.
Yeah, same.
Yeah, so there is a question in the chat. Why does the DSM, the Diagnostic and Statistical Manual of Mental Disorders, not include language that isn't misleading about the gender spectrum? Wouldn't it be the first place to show that understanding?
Do you want me to go? Or do you wanna go?
Well, I mean, I just want to I'll just say quickly what my thoughts are. I mean, the fact that gender dysphoria is even in the DSM, the fact that as transgender people, we have to be classified as mental health disorders. I mean, that's the root of your problem there. So really taking gender identity out of the DSM is the first step. And no, it wouldn't be the first place to show. If you've been in medicine long enough, you'll know it's the last place that things change. And so these institutions are things that we just have to keep kind of working on and eroding, and hopefully just get rid of it in the DSM completely. Because what it does is having gender identity, having gender dysphoria be in the DSM really puts that kind of stigma. Again, we're talking about stigma of trans people. And so it puts a stigma of anybody who is genderqueer or trans as having a mental health disorder, even though we know that's not true. We know that being trans in itself, in its essence, doesn't mean that you have a mental health disorder. And so really just the fact that it is in the DSM is the kind of root of everything. And it has deepened over the years since people started treating transgender people in medicine. The DSM has obviously evolved and it's gotten better with some of the language, but it has for a very long time really deepened the marginalization and the stigma of trans people. And we've internalized a lot of that, and it's just still so pervasive in our communities.
Absolutely, yeah. I mean, all we need to do is really look at the history, right? And so a lot of the time, right, within our community, there's a lot of discussion around, informed consent versus WPATH as a model for medical transition, right? And so just to break down quickly, right, informed consent is you walk in to a provider, say, hi, I'm trans. I would like to begin my medical transition. Please put me on hormones. They hook you up with an endocrinologist, and the endocrinologist makes sure that you go on hormones safely. The WPATH recommends that you do go through a mental health professional first, who, to simplify it down a little bit more, basically gets to say, yes, I believe you are trans enough to transition, or no, I do not believe you are trans enough to transition. And the history of that process is very, very much rooted, like Dr. AJ said, in the pathologization of trans people, where initially people would need to be diagnosed with a mental health disorder in order to be able to transition, in order for a mental health professional to say that they can transition. And so right now we hear a lot of positive things, right, about WPATH, around like how much of a good orientation they give people around transition. But if we look at the roots are genuinely rooted entirely in having to diagnose a person with a condition for being trans. And so today in the DSM-5, right, we have two things that are still very direct descendants of that, and that is the gender dysphoria diagnosis, and that we also have transvestism or transvestic disorder as a diagnosis, which is a direct descendant of a lot of really nasty things like autogynephilia as a concept. And that is all rooted in like very, very blatant medicalized transphobia. But nowadays, because we see these systems evolving and we see them being pushed in a slightly more affirming direction, people think that, oh, now we can trust providers to adequately treat us and to not act like an authority on our identity. But unfortunately, the way that mental health professionals are often trained, especially people who go in to be, gender therapists, is they're trained to, on some level, determine for a person whether or not they're trans enough. And that's why I personally am always a big proponent specifically of the informed consent model, because as a trans person, you know better than anybody else who you are and what you need. And any therapy or any mental health support that you get should be around affirming who you are, not deciding that for you, and not having random metrics like whether you played with enough Barbie dolls as a kid for you to be able to access the medical health care that you need. So yeah, it's a mess. The DSM is a mess.
So, what do you wish healthcare providers who don't necessarily specialize in trans healthcare knew about treating trans patients? We touched a little bit about on just the very stereotypical ways that a lot of medical education is. What do you wish medical professionals who don't specialize in trans healthcare knew?
I mean, really anything. As a primary care doctor, I really think it's the job of any medical healthcare professional, especially if you're primary care, to educate yourself and to know about gender identity and sexual orientation, because you're going to be seeing those patients, and to say, oh, well, I don't understand you, so you can either explain everything about your care to me or you can go somewhere else, is unconscionable. I just don't think that's responsible healthcare whatsoever. So I think basically like just having a general understanding, and also understanding that we're not talking a binary system here, that every trans and genderqueer person is different, that not everybody's going to have the same goals, that not everyone experiences dysphoria, that medical transition isn't the process or the goal of every trans person, that some people have surgeries that others don't. I mean, there's a whole list of things like that that just I guess like when we're talking about, you mentioned, Ivy, the like culture humility piece. I think it's really important that physicians just get a little more than one lecture in medical school on understanding LGBTQ, because we got lumped in together into one to 2 hour long lecture during a 4-year period. So really kind of integrating our identities into every other lecture would be the most helpful, and breaking down that stigma and those barriers.
For sure.
Yeah. I mean, for me, I always say you don't get a choice. You signed up to be a mental health provider or a medical provider. Like, nobody said, oh, by the way, like this population, you don't need to learn anything about, or you don't need to know anything about, and you can just do whatever the hell you want with them and just get rid of them if you don't want them. I literally think I had a Title 10 complaint filed against me, or 9 or whatever, because the medical student asked me, well, what if I don't believe in this blah, blah, blah religion? I said, well, then you should find a new career, because the fact is that, like, as you know, you don't get to do that when you sign up to be a medical, when you got into medical school. Nowhere on your application did it say, like, okay, well, you don't have to worry about queer people. Like everybody else, yes, but queer people, no. So, I mean, I think that is like the beginning, is that you, for me, to tell healthcare providers is that you probably have bias. You have bias against queer people, and you need to accept that and work on it. I mean, over and over in research, it's been shown that medical providers, particularly cisgender heterosexual males, have significant bias against queer people. And, you know, that's just the way it is. And like, we got to go from there. Like, you're coming in with this bias, and guess what, trans people, like, we come in with a bias against you because we don't like you either. We don't want to have to see you, but we have to, because we need to access whatever. So how to have that intersection of these two huge biases coming together to sit next to each other to try to accomplish healthcare? It's the responsibility of the provider to learn how to navigate that, not the patient. And so that is where I think we need to jump off, to start the jumping off point. We don't need another lecture on all of the horrible, like, healthcare inequities that exist for trans people, because there's lots of them, there's tons of them. What we need is the solution, so that providers know how to sit there with a trans person and not be an asshole. And so that's like what, you know, when I talk, and when AJ goes out and talk, and when Ivy go out and talk, you know, we go out and try to teach, and Lane and people teach providers, like, I tell them how to not be an asshole to trans people is like the primary goal of this lecture. And then from there, we can go to make sure that you provide competent care. And if you don't want to do it, at least make sure that you figure out a place to refer people that they can get the health care that they need. Because again, like, nowhere else in this country are we allowed to go look at a population of people and be like, well, you know what? I don't know anything about you, so like, go over there instead, or just like, don't come back here. Go anywhere, just don't come back here, right? So I think that's like the beginning for me.
Yeah, definitely what everyone else said. I think that also, you know, while like I super appreciate the recommendation for people to like refer out if if they feel super out of their depth. A lot of the time, like people who are considered like very trans competent, and this is something that's well known within the community, mental health providers, medical providers alike, people who are considered trans competent also have a slew of issues. But as trans people, we're often used to just dealing with like getting what we get. And a lot of the time we're like, yay, we have an LGBTQ specific, like some type of orientation here. Like we take what we can get. And a lot of the time there's a lot of shame around things like submitting a complaint, right, about a provider who's supposedly supposed to be trans competent, because you're like, oh, why do you want to take away the only resource that the community has? So we really need to have avenues to provide feedback to our providers in ways that doesn't shame us and doesn't make us feel scared, and doesn't result in some type of retaliation or cutting off of services. That's always a big deal. There's very, very little recourse that a client can have against a mental health provider as well. A lot of people do not know what their options are with that. And you have to jump through a lot of hoops in order to have any type of retaliation against somebody, even who, like, you know, ostensibly maybe shouldn't be practicing because of how they treat you because you're trans. So there's a lot of barriers there. And something I guess that I would also say, just in terms of nuance, even if you are a stellar, brilliant, amazing provider, that, you know, maybe you're trans yourself, maybe like you know how to treat trans people and your clients have never had a problem with you, there are still things that are inherently terrifying, traumatizing, and difficult just for a trans person accessing care. And acknowledging the existence and the weight of that trauma, and acknowledging that no matter like how good your services might be and how great of a provider you might be, your clients are still going to have a really hard time, either because of just inherent dysphoria or because of past experiences and medical trauma, or because of things like financial barriers, which is something that a lot of us experience, that most of us experience. Um, you know, there's so many different things that we're already bringing into this space that no matter how good you are, we still need extra support and we still need extra care and we still need an extra like powerful person in our corner. So for anybody who's like really seeking to help trans people, like definitely go the extra mile. Understand that you were absolutely misinformed in medical school, 100%, definitely, no matter where you went. Um, you were absolutely not given enough information to treat us adequately. Consider this an opportunity to fully re-educate yourself and really learn from the community that you're serving before you serve them. So yeah, it's a mess. Also, I saw that question about the form in the chat. Oh my goodness.
So, given that the state of healthcare for trans people, both medical and mental health care, is woefully inadequate and incompetent, and acknowledging the need to get someone strong and the extra support in one's corner, what advice would you give trans folks who are trying to access that competent healthcare? What things should people look for? Are there resources that people should be aware of?
I can go. I'll just go quick because I don't have a whole lot of feedback. The best thing that I've found is talk to your local trans people. We know. We know who's weird. We know who's weird specifically with, you know, non-binary people. We know who's weird specifically with non-white trans people. We know who's, you know, we know all of that stuff because unfortunately a lot of us have had to go through it as like trial by fire. So one of the best resources that you have is your own people. So let's say you move to a new area and you don't know anything about anything. Join a local queer exchange, see what people say. Talk to your local community, talk in a support group, be like, hey, what kind of experiences have you had with this? Thankfully, there's a bunch of online spaces right now. Like, you know, in Connecticut, there's a group called Transgender in Connecticut. There's, you know, there's Queer Exchange New Haven if you're in the New Haven area. There's a bunch of different spaces where people talk pretty openly about their experiences with different providers. And it's super, super useful to just make use of that and trust the experiences of your community. Another resource that I can plug is, it's not very commonly used lately, but it is definitely something that I would encourage community members to use and to like add information to, is radremedy.org, is a website that was put together by and for trans people, to really aggregate information about trans competent care. And it's all broken down by different types of care provided. And you can search by your geographical area. So it's not Connecticut specific, it's everywhere, but it's pretty sparsely populated right now. So if you know stuff to add there, definitely add stuff. If you have reviews for people, it's basically like Trans Yelp, but for providers. I would love to see it being used again more. And it definitely does have some useful information for a lot of like geographical pockets. So I definitely recommend checking that out as well.
I'm going to say everything that Ivy said. And then, if you're looking at a more sort of like national or global, and you might be that little trans kid in the middle of nowhere, Trans Bodies, Trans Selves is a good book. There's a second edition coming out in June, which I think will be more inclusive of non-binary people, whereas the first edition was less inclusive of non-binary people's experience and intersex people's experience. So look for that. I'll make a plug for it. I know the people who wrote the medical transition section. I think that that's a good book that gives you national resources in case you need any help, like legal help. The National Center for Transgender Equality's website is really good if you're looking at document change things, if you need any advice on that. I think it's a good place to go to like get general information. But local, we are our best asset, and sometimes our most challenging. We can be challenging for one another too, right? And I think in smaller places, a lot of the organizations that do trans healthcare were either started by trans people or run by trans people. And I think everybody has to sort of like acknowledge that we as trans healthcare providers come with our own set of like issues around gender and our gender identity and how old we are and when our transition and how that has gone for us. And so, it can sometimes be ultra sensitive. We are ultra sensitive to the community to try to make everything like as best as possible. And so I think the best thing to remember is there's always room to grow for healthcare organizations, and that, like Ivy said, like developing that space where you maybe like a community advisory board is made where a bunch of trans people in the community are allowed to freely and openly and safely say to a healthcare organization, look, we know you're doing well, but this is what you need to do better. And then the healthcare organization actually listen to them, because a lot of times like they'll make these community advisory boards, everybody says this and that, and then they just ignore everything you say, right? Like, so I think that talk to your local people, and then I know that at least for AHI, like that's a AJ is going to listen to you, right? I mean, to what I wouldn't have made sure AJ was there if I didn't think AJ was going to listen to you. So I just think like talking to your local people, but then establishing that safe space that you're allowed to like say we need you to do better in this way.
I don't necessarily have anything else to add to that. I think that's exactly, I would second all of those things. And, as a healthcare provider, I do like to tell my patients, I'm not always going to know everything. If I say something, if I use language that you are not, kind of vibing with, if there's something that comes up, I would really appreciate that feedback so we can grow, so if you are comfortable enough to share, And we are setting up things like patient satisfaction forms that can be anonymous and feedback in different ways. And I think that's really important. I think that, like everybody else was kind of saying, we're so used to just, if we're able to tap into any healthcare for trans people, just accepting it for what it is. And it doesn't need to be that. It really should be healthcare that is gender affirming and supporting you in the best possible ways. So I think all of us, that is our intention with our healthcare centers.
Yeah, I'd like to take this time to ask another question from the chat. That it was asking about the recent CHRO, which I believe is Connecticut Human Rights Office decision, about coverage, insurance coverage for facial feminization or masculinization procedures, and about what the ruling means practically. In the questioner's experience, both providers and insurance companies are either unaware of the ruling or intentionally obfuscate the process of pre-approval so as to deter folks from seeking out this kind of care. They are also curious about the ruling's emphasis on facial feminization and de-emphasis on facial masculinization procedures. What impact does this have on transmasculine individuals seeking care? For sake of conciseness, how can trans folks access cosmetic, gender-affirming procedures through insurance in Connecticut?
I mean, I think one of the main things is taking it out of the realm of cosmetic, right? Like understanding when you're writing the letters to make sure that you're putting in language that says this is a medical necessity and to give reasons. And there are some good examples online on how to, if you're a provider, how to write a letter that does support things like FFS as having, as being medically necessary, not cosmetic. We really need to get away from that language because insurances will never cover something that they believe to be cosmetic.
Ultimately, it goes back to understanding what happens in puberty, and that healthcare providers don't realize, like, a testosterone-driven puberty changes the shape of your skull and your jaw, and it changes the thickness of your bone. And if you go out into the woods and you see a skeleton lying there that's just the skeleton anymore, they can tell the difference if that skeleton was a testosterone-driven versus an estrogen-driven puberty, right? And so the cosmesis of it is irrelevant because it's not about cosmetics. It's about if you went through a puberty that was not consistent with your gender identity. First, you are left with certain things that only surgery can correct. And the whole goal of puberty suppression is to ensure that you never have to go through those things which surgery have to correct, i.e. breast development if you're a transmasculine person. Like, the only way to correct that is through surgery. And so, ultimately it's going to have to be that we're going to have to keep suing the state. I mean, and if you feel, if you're one of those people who, I've been through a CHRO case, I can tell you it's not easy, but like, if you have that guts and you have you get to the provider who will, make sure that, they understand like what has happened and why it's not a cosmetic procedure, then that it's a safety issue for a lot of trans people. We just have to keep suing Connecticut every time that those things get denied. And eventually, it will happen. The scary part is how many trans people have to be murdered before like the lawsuit until we sue them successfully. But this is the way that all things have changed for trans people when it comes to insurance, is that we've had to sue and for our rights. And for masculinization procedures in the face, it is a challenging surgery. And I think they don't sue, they don't make because there's probably nobody in Connecticut who actually does it, who takes Medicaid. It's easier for them to just get away with, say, making a ruling that says like you don't need it, because there's nobody who does it, and there's barely anybody who does it in the whole country, really. So I think as the surgeries, as we get better at surgery and people get better, I would suggest, I should never say this. This is probably all being recorded, but like I can tell you the only way that people have gotten successful is to sue for their own rights, right? And to file CHRO complaints every time that these things are denied. Please somebody else say something so I'm not the only one on camera who says sue.
I don't have anything to add beyond that because that was brilliant. But yes, please sue people if you don't get what you need.
Yeah, I mean, I'll third that. Absolutely.
As long as I'm not the only one saying it when the dark van with blacked out windows comes and unmarked to take me away. So
Um, So, are there any policy changes that you think would make the state of trans healthcare more equitable? Um, we've discussed just in that previous question a little bit of the frustrations with current policy and in regards to what medically necessary procedures it regards as cosmetic. But wider policy changes, are there any that you can think of?
I mean, personally, I think that a lot of access issues would be eliminated by making healthcare a human right and making it free across the board. Like it is in a lot of places. And you see in a lot of those places that the quality of trans healthcare is also on the rise very fast. So having more people be able to access healthcare would generally correlate with better development of healthcare, which makes sense. So that would be one of my priorities personally. But also, I mean, anyone who knows me knows that I harp on a lot about banning IgM, which is intersex genital mutilation at birth, which is still legal in our state and in everywhere in the US, pretty much. California issued a recommendation against it recently, which was a big development, but that's the closest thing to an actual ban. And then, yeah, I mean, I guess I'm honestly at a loss because it keeps coming back to so much of healthcare is based on inaccurate information and based on like inability to properly treat trans people. So any type of mandate that actually changes curriculum and changes, what people are told to do to people. But maybe the doctors could speak to that a little bit more. From a mental health standpoint, I'm always a big proponent of informed consent with regard to any type of treatment or hospitalization. So our service is fully informed consent based. We don't call emergency services on people or hospitalize people unless they ask us to make that call for them. And I would definitely urge for policy changes that allow more nuance and more consideration of a person's agency for anybody who's currently a mandated reporter, and a better understanding of, how crisis actually works, how suicidality actually works. What does it mean to respect a client's agency, and what does it mean to, not re-traumatize them by subjecting them to non-consensual treatment or hospitalization?
well, I mean, ultimately, we need to have some federal guidelines or federal guidance around hormones, surgeries, etc. I mean, remember, there are only 14 states in the United States where hormones in surgery are even covered by Medicaid programs. So, the states run their own set of guidelines. But if there was an overarching federal guideline that mandated state Medicaid programs to cover hormones and surgeries, that I think certainly would expand access to healthcare for trans people across the country, as opposed to, you know, there being a cluster of states in New England, California, and like the Pacific Northwest that do this. And then everywhere else in between, it's like crickets, you know, and you have to figure out, and they need to really strengthen the protections that we do have, because they're so like dismantling one teeny portion of the Affordable Care Act will eliminate all of this healthcare coverage. So, you know, allegedly, Joe Biden is going to make sure that every trans person can get healthcare in the United States, according to, you know, but whatever. I don't know. I'm old. I come from a pre-Affordable Care Act time when nothing was covered and girls were going to prison for selling their HIV medicines to get hormones. So, I mean, you know, the fact is that there needs to be some kind of federal guidance around making sure that hormones and surgeries are covered for trans people, just like, you know, making sure that, you know, kids get their vaccinations. The same things need to apply to our healthcare as apply to everybody else's healthcare in the United States. So, I mean, that's a big dream, but like, if they could change that, that would change a lot of stuff.
Yeah, I don't have anything to add to that. I completely agree with that. I think that the fact that in July, Trump could roll back our protections to the point where doctors can basically deny trans people just for being trans access to care is startling. Things like that shouldn't be able to happen. So any rulings that precede that, yeah, anything like that would be really great on a federal level.
Yeah, I'm just going to say that, you know, the rulings that this year the Supreme Court made, in my mind, are the most important, the most important civil rights actions that happen for trans people in the country that thus far, making sure that we're protected in employment, at least, right? Like federally. You know, gay marriage is great and all and blah, 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 but like not all of us want to get married, but most of us want to have a job and need to have a job to function. So the protection in the workplace, you know, I think was by far the most important thing to ever happen for trans people in this country. We just need to like keep it going and like make sure that, you know, healthcare gets rolled into that on the next level.
All right, so that brings us to about the end of our time. Thank you all so much for spending an hour on your busy Wednesday to talk about trans healthcare and your passion for healthcare and making healthcare better for trans people. Gonna welcome, there's gonna be a little message from the executive director of the Pride Center, Patrick Dunn. And yeah, we'll say goodbye to Ivy, Dr. Eckert, and Dr. Damodant. Thank you so much for joining me.
You're amazing. You're amazing. You're amazing. Thank you. Thank you. Thank you.
Bye.
So thank you again, everybody who joined us today for this important conversation. As Maya mentioned at the beginning, this program is a part of our larger Trans Awareness Week program, which runs through Friday, concluding with Trans Day of Remembrance on November 20th. You know, this is an important time. I want to thank Elliot, our trans non-binary intersex program officer, who has put together this entire week of programming within his first month of employment. So I give him a big shout out. If you do want to get in contact with Elliot, he is available to chat. And as we continue to build trans non-binary intersex focused programming here at the New Haven Pride Center, I do want to very quickly just share share that the center was recently awarded an incredible national level $25,000 match grant, which we are trying to match by December 31st. So if you have an extra $1, $2, $5, $10 that you are able to give to support the important work of the New Haven Pride Center, please visit newhavenpridecenter.org/match. And every dollar you give will become two. So you have an opportunity to make a big impact right now by making that contribution. So again, I want to thank everyone for being here today. I want to again thank all of our incredible panelists and of course Maya, who moderated. I hope you all have a great rest of your day, and I look forward to seeing you all on Friday for the Trans Day of Remembrance. Thank you so much and have a great one.